I'm going to be talking initially about the pathogenesis, epidemiology of C. diff, as well as some clinical features and diagnostic testing, specifically the diagnostic testing assay we use here at Georgetown. And then after that, Dr. Copeland will talk about our current C. diff rates, as well as some policies and initiatives to reduce those rates. One key thing is, just for time's sake, we won't be talking about treatment of C. diff because that could be a topic, talk on its own. So, Clostridioides, formerly known as Clostridium difficile. It is a gram-positive rod, spore-forming, an obligate anaerobe. It was first identified in 1935. The actual name difficile references the slow and difficult growth in media, hence why our standard stool cultures actually do not grow out C. diff. And the classic hallmark feature of C. diff, pseudomembranous colitis, has been documented as early as 1893, but it wasn't really until the 1970s, with the advent of lincomycins like clindamycin, that rates of pseudomembranous colitis increased, and research around that time found that the causative agent, actually in hamster models, was revealed to be C. diff. So going through the pathogenesis of C. diff, this is kind of like a streamlined flow chart. Initially, oral inoculation, germination, colonization. From that point, you can have latency with lack of clinical symptoms and even clearance without treatment, or clinical disease treatment. And unfortunately, with C. diff, one of the key components of this illness is a very high recurrence rate. We'll go through each of these in detail. And just so you know, there's barriers along each step from both the innate and adaptive immune system, as well as the gut microbial flora. So first and foremost, oral inoculation of spores. So one key thing about C. diff is that it's ubiquitous in our environment. Everyone in this room at some point in their life was colonized with C. diff. It is found and widely distributed in both the toxigenic and non-toxigenic strains in soil, water, animals, food products, and surfaces. Water, it's found in water, and it's even been cases of contamination in tap water supplies. There was a notable outbreak in Finland in 2007 when sewage kind of contaminated drinking water, and it led to a very large outbreak. It is found in stools of almost all mammals and is known as a veterinary disease as well. It is found in food products at very low levels. So the inoculum is not high enough to be considered a foodborne pathogen, but just so you're all aware, it's been found there as well. But the key one here, especially for hospital-acquired cases, is along surfaces as fomites. Spores are very robust. They survive alcohol. And even when we're using bleach, it takes 10 minutes of bleach exposure to adequately eliminate C. diff. So basically, again, it's found in a lot of places, very easy to unfortunately get ingested. But just ingestion, for lack of a better term, of C. diff spores does not lead to all germination and colonization. There's specifically multiple steps that have to occur. And there's a lot of innate barriers to germination and colonization in our patients. The biggest barrier is our indigenous gut microbiota, and it plays multiple key roles. One of the important ones is actually metabolism of bile salts. So the primary bile salts that exit our liver are found to be very potent stimulators of both C. diff spore germination and vegetative growth. And this is actually an area of active research in helping reduce C. diff infections and recurrence rates by ways to target primary bile acids. Additionally, a lot of our microbiota create specific microbial products that have direct antagonism against C. diff. One example is an organism called Bacillus thuringiensis that produces a strain of bacteriocin that has very similar and narrow activity to C. diff as metronidazole. Additionally, our microbiota augments our innate immune system as well. And one way it does this is by breaking down nutrients into short-chain fatty acids. And with our immune system, we have both the innate immune system, things like toll-like receptors, cytokine response, innate lymphoid cell response, and even eosinophils have been implicated in our innate immune response to prevent germination colonization and our adaptive immune system. So, in fact, the levels of toxin-specific IgA has been inversely correlated with the risk of C. diff recurrence, to the point where now we actually use monoclonal antibody therapies for patients who are very high risk for recurrence to help reduce that recurrence risk. And also, very interestingly, colonization with a non-toxigenic strain through competition. So folks who are already colonized with non-toxigenic C. diff strains have that has a protective effect against toxigenic strains. So going into the epidemiology, remember I mentioned everyone here in this room has been colonized at some point. That goes into, there's nearly 100% colonization rates amongst children from ages 0 to 3, at least at some point during that timeline. And this kind of goes back into the ubiquity of C. diff spores in our environment. But interestingly, in the pediatric population, clinical C. diff rates are really rare, and frequently they have changing strains of C. diff on stool sampling. But, in our adult population that we're dealing with mostly, the general colonization rates amongst the general population is about 3%. That rate rises when we're talking about hospitalized and nursing home population to about 8 to 22%. And of all C. diff cases, hospital care associated is about 80%, as you can see in the graph on the right. So what about someone coming into the hospital who is not colonized? Unfortunately, the general acquisition rate is about 21% for our folks coming into the hospital who are not initially colonized. But the key thing to remember here is that despite acquisition, 60 to 80% of those patients will remain asymptomatic. So they will be considered in the latency period or a carriage state. When talking about epidemiology, I'd be remiss not to mention the NAP1 strain. So as you can see in this chart here, this is from the HRQ, the rates of C. diff infection in the US had a pretty dramatic rise in the early 2000s. And this is correlated to the emergence of the NAP1 strain, which is also known as the North American Pulse Field Gel Electrophoresis Type 1, for those who don't like acronyms. This strain emerged from North America in the early 2000s and became the dominant hospital-acquired strain, not just in the US, but around the world. And those numbers, those dramatic rise in C. diff rates correlate not just in the US, but also worldwide. The other thing to note about this NAP1 strain is that it was associated with higher levels of toxin production and hence higher morbidity, mortality, treatment failure, and recurrence rates. So what are some risk factors for developing clinical C. diff infection? The number 1, 2, and 3 are antibiotics, and not just antibiotics, but there's a dose correlation as well. So the number of antibiotics matters, the duration of treatment matters, and the type of antibiotics. The highest risk include, as we all know, clindamycin, but then also fluoroquinolones, and then second generation or higher cephalosporins, followed by penicillins, macrolides, carbapenems, and even vancomycin, metronidazole are considered moderate risk. Everyone's probably heard about PPI and H2 blockers association with C. diff. There's been a retrospective analysis have shown that it does increase risk about 1.4 to 2.75%. But notably, there's been no prospective trials have shown a causal relationship, and the actual risk relations to dose and duration is not well documented. Some of the other risk factors include patient age, prior hospitalization, severity of underlying comorbidities, abdominal surgery, NG tube use, duration of hospitalization, and long-term care residency. One important thing to mention, especially here at Georgetown, where we see a large IBD population, the C. diff, especially in our UC population, which can have very, very high incidence rates. In fact, up to 9% of patients hospitalized with an IBD flare can be accounted to C. diff. Compared to non-IBD patients, C. diff in our IBD population is associated with a higher short and long-term mortality and associated with a younger patient population. And more commonly, they may not have some of the traditional risk factors, right? So they may have the community-acquired cases and it not being associated with recent antibiotic exposure. And the thought is that and especially in our UC population, these folks already have a baseline disruption in their indigenous microbiota and more persistent disruptions. So even without the stressor of a antibiotic, they may develop propagation of C. diff. And of course, a lot of these patients are also on immunomodulatory agents at baseline for their IBD. Okay, so now going back to the flow chart, let's imagine, we have germination colonization. Again, it can go into latency or go into clinical disease, or it can go from latency to clinical disease from a stressor. But the key thing about clinical disease, we're talking about is that the clinical symptoms are related to toxin production. And there's two really well-documented toxins that mediate clinical disease. That's toxin A and toxin B. Both are produced in the gastrointestinal lumen and bind GI mucosal cell membranes to form endosomes. And once within the endosome, then they create pores that allow the toxin to enter the cytoplasm, where they have both cytopathic and cytotoxic effects. This being said, while the toxin's effect is mostly mediated through this process, there have been cases, especially in our severe cases of C. diff, where toxins have been found in the bloodstream. And it's probably a reason why some of our sicker patients with C. diff have more systemic effects as well. But the one thing I do want to emphasize, presence of toxin does not equate to clinical disease, right? So all our testing assays only detect the presence of toxin. And if it's not at a level high enough to produce symptoms, it's by nature is not C. diff infection. But if you do have infection, like actual clinical symptoms, this is our hallmark finding is pseudomembranous colitis. The histopathology on the left shows the classic findings of significant neutrophilic infiltrates with a fibrinous exudate and epithelial disruption. And then on gross anatomy, from a colonoscopy, you see these classic findings of multifocal, about 1 to 2 millimeter plaques on a background of normal colonic mucosa. Initially, they may be sporadic, but as the disease progresses, it can coalesce and cover the entire colonic wall. Again, clinical features can vary, can be asymptomatic carriage to fulminant disease. And the key hallmark symptoms, of course, we all know is frequent diarrhea, right? At least 3 episodes a day, with other associated symptoms, including fever, abdominal pain, and tenesmus. Interestingly, right, 20 to 25% will self-resolve with discontinuation of the precipitating antibiotic, even without C. diff-directed therapy. And there are cases of some rare extracolonic manifestations, despite the fact that the true ecological niche of C. diff is in the colon. There are cases of bacteremia, reactive arthritis, peritonitis, appendicitis. And specifically in our IBD population, we've had colectomies. There are cases of small bowel enteritis in those folks who have like ileostomies or pouch anastomoses. Again, we're skipping treatment, but I do want to talk about the high recurrence rates of C. diff. And that's due to really two key features, right? Persistence of spore colonization. So all the treatments that we have against C. diff are really only active in its unsporulated forms. So notably, patients can shed spores for weeks after completion of C. diff treatment and the resolution of symptoms. And because, again, these spores are very robust, it's very easy, even if you do truly clear all the spores, to reacquire spores from the environment, especially in our folks, who at times are at home and maybe re-inoculating themselves from fomites in their home setting. Risk factors for recurrence, severity of the prior infection for C. diff, antibiotic use, both concomitant as well as post-infection, older age, prolonged or recent stay in healthcare facility, immunosuppression, PPI or H2 blocker use, and the NAP1 strain, specifically because of the higher levels of toxin production is what the thought is. And with each subsequent episode, that recurrence rate increases. So the first episode, at least with oral vancomycin, is as high as 20 to 25%, and you can see up to 65% for the third or more episode of C. diff. Next, let's talk about diagnostic testing. This is going to be rehashed over and over again by myself and Dr. Copeland, but remember, right, because of the high carriage rates within our hospitalized population, you must have the classic clinical symptoms plus lab diagnostics to say someone has true C. diff infection. And remember, stool cultures won't capture it, right? The difficile in the name is for the difficulty in it growing. And there's a variety of tests. I'm not going to go through all of these, but we'll target the one we use here at Georgetown, which is the two-step GDH assay. So what is this test? So the initial screening is a glutamate dehydrogenase, EIA. So glutamate dehydrogenase is an enzyme. It's present in a lot of bacteria, but at very, very high levels in all strains of C. diff. That's important. So both toxigenic and non-toxigenic strains. So it has very good sensitivity and excellent negative predictive value. If that is positive, then we do a confirmatory toxin-mediated test, toxin EIA, for confirmation of a toxigenic strain. And this has improved really excellent specificity, but lower sensitivity. The reported discrepancy rate is about 13 to 19%. So that's when it's a positive GDH, but negative toxin. And in the majority of those cases, it's thought to be because of a non-toxigenic strain of C. diff. We don't use the PCR or nucleic acid amplification test, but I do want to mention it as you may be able to see it in an outpatient setting. It does have an excellent blend of speed, sensitivity, and specificity, but is expensive. And it can be considered too sensitive, especially when used in like multiplex PCRs, where it can detect even very small levels of toxin, which may not be causing the clinical symptoms. So we've actually removed it from our stool biofire here at Georgetown. So this is the flow chart of how the testing works. So you order C. diff testing. The initial one is a GDH assay. If that's negative, great. You've ruled out C. diff infection. If positive, then we reflex this to a toxin EIA. If that's positive, then that suggests there's a presence of toxigenic C. diff. Keep in mind, I did not say that it confirms C. diff infection, right? Just a presence of toxigenic C. diff. It's up to you to determine clinically if that C. diff is causing the symptoms. And if negative, then suggesting that it's suggestive of ruling out C. diff. These are my sources, and then I'm going to hand off to Dr. Copeland for the rest of the talk about Georgetown-specific data points and initiatives.
Okay. Thank you, Kevin, for getting us all on the same page. Now is time for the public shaming. I'm kidding. I'm kidding. I'm not going to do that. But we're going to pivot here, and we're going to talk about our own C. diff rates in the hospital. I'm going to show you our data. And none of this is confidential, but I ask you to use this information with your discretion. You know, we're here all today to help our patients. But what I'm about to show you would not be considered good news. To be frank and to be brief, our C. diff rate has risen significantly. We're now above the national goal, the MedStar goal, national average. This trend probably correlates with increased antibiotic usage, longer hospital stays, and increased complexity of the patients that we're seeing. Why is this important? Number one is safety. We should do the best job we possibly can to protect our patients from harm. Harm comes from actual C. diff infection, but it also comes from identifying patients who don't have infection but have a positive test. Those patients we consider colonized, and that comes from excessive antibiotic usage. Even vancomycin, fidaxomicin, metronidazole have been associated with C. diff recurrence. Second is our reputation. Our patients should feel confident in our ability to protect them from becoming sick while they're in our care. And then lastly, rates of hospital-acquired C. diff is a quality metric by CMS, and it directly affects our hospital's reimbursement. So that perks up a lot of years too. As physicians, I think our hands are strongest in education, stewardship of antibiotic stewardship, and then identifying the proper patients to test. And so what I want to do is provide you all with some points, some data about what we're seeing in the hospital, some actionable items, and some initiatives that we're starting with this fiscal year. But first, I want to tell you a little bit about the lingo that we use in the hospital and how we're judged. As Dr. Jiang mentioned, humans are first colonized with C. diff through an oral route, and the time from initial colonization to development of infection can vary significantly. Some patients might develop infection within 3 to 7 days of acquiring C. diff. Some patients might not develop infection at all. That probably depends on the host, the inoculum that patient gets, the type of C. diff that patient acquires, and other exogenous factors like antibiotic use. But both definitions, infection and colonization, require a positive test for you to say definitively that's the case. The difference is the presence of disease manifested with symptoms. Sometimes the term false positive is used in conjunction with a colonized patient. That's not the correct terminology to use. As the suspected minimum incubation period for C. diff infection is 3 days, any patients presenting to the hospital within 3 days, or any patients developing disease within 3 days of hospital admission are diagnosed of having community onset disease. If a patient develops disease or has a positive test hospital day 4 or later, then it's considered a hospital onset case. Although, as you can now tell me, a lot of patients will come in colonized with C. diff and then blossom or develop infection later in their stay. So it doesn't necessarily mean they acquired it while they're in the hospital, but for the senses of judgment and national safety data, it does. The National Health Safety Network uses lab ID events to identify C. diff diagnoses. So whether a patient is colonized or in a disease state, it counts to our record if they have a positive test. Positive test is a positive test. And so for the purposes of this talk, I'm going to be talking specifically about hospital onset cases. And so this flow sheet here is the exact flow sheet that the NHSN uses to distinguish between community onset and hospital onset cases. I next want to introduce you to the standard infection ratio, which is the preferred NHSN calculation for inter-hospital comparison of C. diff rates. This is different than what we usually follow, the C. diff rate, which is occurrences per 10,000 patient days. And that's actually defined by the IDSA and SHE as the best way to follow inside the hospital, but the National Health Safety Network uses this SIR. And they use this because it is reportedly going to allow better comparison between hospitals of different acuities. And so we send our data to NHSN and they give us an SIR back quarterly. And we calculate our own rate and incident monthly. In simplest terms, and that's probably the best I can give you, the SIR is a ratio of actual infections to the predicted number of infections a hospital would have. You want this number to be low. In 2015, there was a goal set for national reduction in SIR to about 0.7. And that's a 30% reduction. And that's a goal that nationally we reached, and we actually went even further than that goal. So as a nation, we're meeting what we want with C. diff. You might be thinking to yourself right now, as I thought to myself many times, how do they know how many infections our hospital is expected to have? It's a lot of math, and if I tried to explain it to you, you would probably lose some respect for me, so I'm not going to do that. But as I understand it, data is collected about our hospital, and it's weighted against multiple risk factors for C. diff events. And these are the risk factors that are listed in the NHSN document on SIR. And so you see, it contains a lot of things you'd expect. How many ICU beds you have, whether you're in a facility with oncology patients, you're a teaching facility, the size of your bed, and all of these are weighted and give an expected amount of C. diff cases that you would expect to see. Interpreting an SIR is much easier. You want a low number, the lower the better. And if you have a number greater than 1, that means you really have a problem. Greater than 1 means you had more infections than would have been expected for that case. Less than 1 means you had less infections than were expected. And that's our goal, is to continually improve. And so here's our data. This is our C. diff data from 2021 to 2024. The peaks are high, the valleys are low, and if we could just stay in that valley range, then we'd be doing great. I think we realize our problems, we make adjustments, and then we find out, as everyone finds out, that sticking with those adjustments and keeping them consistent becomes difficult. Fiscal year 2022 was a good year for us. During that year, myself and a lot of my colleagues in the infectious disease department and the infection prevention department performed C. diff test audits. And some people in the audience might remember, if you ordered a C. diff test and that soft stop popped up and said, this patient doesn't meet requirements for C. diff testing, and you overrid that that stop, we would review the chart and then contact you and try to come up with a plan on, is this a patient that we should test for C. diff, or is this a patient that could have, something else going on? And this was a highly effective process for us, but it was resource intensive. And in Q2 of fiscal year 2023, when we stopped performing this, we saw a rebound in cases. And fiscal year 2024, we've seen the most cases in the past few years. So you can see here on this graph, the SIR is represented in blue. All in all, in fiscal year 2024, the last year, our SIR was 0.71. I want to point out here that at the bottom of this chart, you can see the actual number of cases of C. diff. 20 C. diff cases in 1 quarter, in 3 months, is a bad number for us. And so they're not a lot of cases, but still every single case counts. We should be taking this as seriously as we take our CLABC rates. This is a more in-depth look at fiscal year 2024. The line on this graph here represents the rate of C. diff occurrences per 10,000 patient days. Looks like a steady climb here. So all in all, like I said, through fiscal year 2024, our SIR was 0.71. This is what we look like compared to other hospitals in the MedStar system. When I was reading through SIR calculation, there were a lot of arguments that it's still not the best to standardize between higher acuity hospitals or academic centers. And so I haven't seen anything that they're going to change SIR calculations, but we do sometimes stick out compared to community hospitals. Now that you know what our problem is, I want to tell you what our goal is and some of the things that we as physicians can do to help. I want to make this simple for us. So in the next few slides, I'm going to give you very direct things that we're planning on doing. But our overall goal is to reduce our SIR through fiscal year 25 down to 0.448. And that's better than the benchmark that came out previously by NHSN. It's lower than the MedStar benchmark this year, which is 0.52. It's lower than the national average from 2022, which was around 0.5, but probably a bit lower now. This is our minimum goal. We'd love to get lower than this. And so we don't want to get to 0.448 and then stop and say we're good. We'd love to get even lower, 0.3, like we've had in some really great quarters, or lower than that. The SIR still feels a little bit hard to grasp, so I'll give you some solid numbers. Our C. diff occurrence amount was 76 in 2024. We need to bring that down to 48 or less to hit that SIR mark. So as physicians, here's three simple things that, well, I shouldn't say simple, but here's three straightforward things that we can do that will help bring down our rates. One is wash your hands. We should encourage others to wash their hands. We should encourage our patients to wash their hands. And I'm going to talk about that in a bit too. Number two is to be conscious of who you're screening. Ask yourself that colonization and infection question before you send the test. If I send this test and it comes back positive, and I was going to think they're probably colonized at that point, then maybe you don't need to send the test. And allow yourself time to change your mind. If you send that test and later the patient starts having form stools and they start feeling better, we can cancel that test. And then three, be antibiotic stewards. We can all do that. We can all be better at it. I know that I can be better at it. And these are three simple things that we can add into our work every single day that will help bring this rate down. We've all focused on our hands as far as washing and our associates' hands. And I know that by the end of the day, I have so much hand sanitizer on my hands that it feels like those things that you would buy that you put your hands in, like the paraffin wax, and then peel it off. But we also need to focus on our patients' hands, our patients who are bedbound, who need help getting to the bathroom. How many times do we think that they're washing their hands throughout the day? Simple things like that can have a big impact. Patient hand hygiene is one of those things that seems like it would be obvious to us, but it gets lost in that shuffle of, we got to move this patient around, I got to bring in their medication, I got to get them to this test, here's your food, but we still have to do all these other things. Asking these questions can allow nice cost-effective strategies. And this group of researchers asked what happens to our C. diff rates if we make an educational push to patients on hand hygiene. If we ask our nurses to just offer, would you like to wash your hands before you eat? Would you like to wash your hands after you came back from that test? What they found is that if you can get your patients to wash their hands on average once more a day, you can make a difference in your C. diff SIR. And there's probably a lot of confounders in this study. This was a group that knew they needed to get their C. diff rates down. So there were probably other initiatives that were occurring around the same time. But it makes theoretical sense. And it adds little to no extra cost. And their efforts in education lasted for about 3 quarters. And then things sort of trailed off and their SIR rebounded afterwards. Patient hand hygiene and hygiene in general reduces all hospital-acquired infections. Starting within the last month, with help from infection prevention team and the SMART team and the C. diff presidential goal, patients are starting to receive hand hygiene wipes with their meal trays. And I still recommend that we tell our patients, if they can, to wash their hands with soap and water. But hand hygiene wipes, even the mechanical action of wiping away stuff from the hands, can help prevent C. diff spore ingestion. And I would love to bring up more data on hand washing, but I wanted to get through a couple other things. But I think it's simplest to say that For many, many years, thousands of years, patients were dying because we didn't understand the importance of hand washing. And so we owe it to them to not put ourselves back in those dark ages. So let's move on now to diagnostic stewardship. And I think of diagnostic stewardship as like mindful or intentional ordering, avoiding that reflexive nature that we all sort of feel in the middle of the night when we think we just need to do something. In the world of C. diff, if you send a test thinking that it probably should be negative, but we're just going to send it because it just can't get it out of our heads, and it comes back positive, probably still is a colonized patient, and that's still going to count towards our C. diff rate. I've sent many tests where I wish I could live in ignorance of the result and didn't really plan to do anything with it. So we all learn from those experiences. But as I said many times, the real issue with C. diff is that if you send enough tests, you're going to get positive results. If we tested everybody in the hospital for C. diff, we'd probably find that anywhere between 4% to 15%, maybe up to 22%, like the study that Dr. Jane brought up, are going to test positive. And the vast majority of those patients will not have C. diff infection. The positive predictive value for infection when you're screening an asymptomatic patient is low. And sure, we'll find those colonized patients, but that's not why we send the test. A good chunk of our admitted patients are going to be colonized, probably more than you think, especially if they're coming from a nursing facility. Our tests can't distinguish between colonized or infected patients. Our judges, CMS, won't distinguish it either. And so we're the only ones that can make that distinction. Even if we say in the chart many times this patient is just colonized, doesn't have a C. diff infection, it still counts towards our rate. So here is our current testing criteria. And so if you are ordering a test and your patient meets these criteria, the test will go through. If they do not meet this criteria, then you'll get a pop-up that says this patient doesn't meet testing criteria for this specific reason. All patients should have diarrhea. Our algorithm doesn't make an exception for ileus because presentation of C. diff with initial ileus is a rare presentation. But we all know that there are cases where some patients will present initially with ileus, a post-surgical patient who's on antibiotics, who's also been receiving opioids, or someone is coming into the hospital very, very, very late with C. diff and megacolon. Probably in those cases, it'd be hard to get a stool sample anyways, but vast majority of patients with ileus do not have ileus from C. diff, so we don't include that in our initial testing criteria. You have to be laxative-free within the previous 48 hours. You should have some evidence of inflammatory diarrhea. That could be fever, leukocytosis, colitis, abdominal pain, fecal urgency. And then we also don't recommend testing patients who have had a positive test within the preceding 8 weeks. And that's because it can take time for that test to become that negative. So if your patient has diarrhea and has a negative C. diff test, that's fine. But if you have a positive C. diff test, it could still just be related to the initial infection. And so in those cases, it really takes clinical reasoning. If it seems like it's a recurrence of C. diff, we will often just treat. Our algorithm is a soft stop because we value physician autonomy and we value the opinion of the physician that's at bedside. Other institutions have hard stops where you absolutely cannot order the test. In order to order it, you have to call the laboratory department or whoever's on call for C. diff ordering. With our test, you can bypass the criteria and order it. And we have seen cases where stools are not documented. Someone who really is having diarrhea and it's just not being put into the chart. Someone hasn't gone in and entered those orders yet. And we realize that that happens. And so we have a soft stop, but we will often review those cases that override that soft stop and make sure that it's not an appropriate test. Okay. I'm going to show you two recent studies that came out looking at how safe these soft stops and hard stops are. As probably a lot of you are thinking, what if we miss that patient who has C. diff? And they get very sick. Does that happen? And so this study from 2023, they used a hard stop where you cannot order the test. You have to contact someone who can then order the test. In over a year, they had 289 test overrides, and 41 of those tests were eventually canceled because of no specimen. 248 were eventually completed, and 11% of those tests came back positive. And when they reviewed those cases, all patients actually met initial criteria. Most often it was because there was no stool documented in the chart. And so if you remove those patients who should have been allowed to have C. diff tests in the first place, the majority of tests that were ran anyways would have been negative. This was another study that came out from University of Virginia, and I think the way that they did it is a lot more similar to how we do ours. They use a soft stop, again, a clinical decision support tool, and they looked at their rates over about 6 months. And that decision support tool prevented 147 tests. There was no change in the primary outcome of mortality or ICU transfer in those patients who had a test that was prevented. 54 of the prevented tests were eventually reordered and sent in 7 days, and 11 of those came back positive, but there were no adverse C. diff events in those patients. So these seem to be safe mechanisms to use. We continue to evaluate our process, and if we find cases that were unsafe related to it, we go back and we review those, but they do seem to be safe to use. And so I encourage you to believe that these are useful tests. There's a lot of ways to promote diagnostic stewardship. Some work better than others. The clinical decision support tools, they usually work very well in the beginning. And then once you've clicked past it once or twice, it becomes a little less scary. And then we see sort of recidivism in the C. diff rates. Second thing is we're trying to avoid these reflexive tests, the cross-cover overnight C. diff tests, where some person or physician is seeing a patient, they seem sick, want to help, order a C. diff test, but maybe later that day, something else was found to be the cause, but that C. diff test is still sort of hanging in the balance and doesn't get canceled. And so those are the kinds of situations that we're trying to avoid. And another helpful thing is to really ask your patients to qualify their diarrhea. Are you really having continuous diarrhea? Is it watery? Do you remember that you had a laxative at some point and since then you've been having diarrhea? That's helpful to re-stratify these patients too. Third is know that you can cancel your test. Like I said, if your patient no longer meets criteria for C. diff testing, their diarrhea has resolved and your test hasn't come back yet, we can contact the lab and ask them not to run it. We're working on ways to make that more streamlined, a little bit easier, because I know it really adds a lot to your workflow to get onto the phone and try to reach someone to do that. So we're looking for ways to make that easier. We are performing reviews of our lab ID events. So anyone who has a positive test, we go back and review the chart. In past reviews, when we've had higher rates of C. diff, we found that maybe 30% of our cases were likely not true C. diff infections. And these are patients who had diarrhea resolved immediately during the day, patients who had reported diarrhea for months, who continued to have diarrhea for months after trials of treatment for C. diff. Patients who very recently had a C. diff infection, so it wasn't a new case, or patients who were seen by an ID team or a GI team. Eventually, the diarrhea was contributed to something else. Our lab has stool consistency requirements so that you don't send those Bristol type 1 stools to the lab for C. diff testing. But basically what it says is that if the stool conforms to the outside of the container, that's an appropriate sample. And so our lab does review stool for appropriateness as well. We're going to start auto-canceling tests that haven't been collected within 24 hours. And that's sort of a safety net for those patients who have resolution of their diarrhea within that event, so that we don't collect inappropriate stool. We've looked back, and it's very, very rare, if ever, that stool is collected that late. And so we don't expect this to be a safety issue, but those will be things that we continue to review. Some hospitals like Washington Hospital Center are restricting testing times. We are not, don't have a process to do that, but there are some institutions that do that. And then lastly, you can always ask us to help, ideally with a consult, shameless. But if you're open, we are willing to help figure out that situation, and we could help either cancel the test or prevent sending a test, or get the test sent if we really think that a patient should be tested. This is what our C. diff ordering habits look like. We're very active in screening in mid-morning, in the early afternoon, and that makes sense because that's our common rounding time. But if you look at the number of tests that are sent after hours, that's between 5 p.m. and 7 a.m. It's about 30 to 40% of our tests. And sometimes these are ordered by covering providers who we talked about might be uncomfortable in missing an actual C. diff case and want to do something for that patient tonight. But because none of us really wants to miss a C. diff case. But we're looking at there are ways that we can reevaluate these tests earlier in the morning about whether, that patient still meets indications for C. diff testing. Here's a stewardship challenge that we often see, is that patient with unexplained leukocytosis. And I remember from my training, it was commonly said that there are some infections that are likely to cause high white blood cell counts, more than 25,000, 30,000. The number changes sometimes. And these researchers looked at that because they were not sure that that was really the case. And so they reviewed 12,000 patients who were tested for C. diff, and that's probably the most amount of patients I've seen in a C. diff related research study. They found that there was no correlation actually between what the actual white blood cell count was and the positivity of C. diff test, and that most of the patients who tested positive for C. diff actually had lower white blood cell counts. And so they state specifically that there is no value in sending a C. diff test for patients with unexplained leukocytosis who are not having other symptoms of C. diff, like colitis or diarrhea. And then they also found that a lot of patients with C. diff had lower white blood cell counts, and those are the ones that we qualify as mild to moderate cases. So a white blood cell count in itself is not a fully sensitive test to rule out C. diff. And I'm going to end here with one slide on stewardship. And we have an excellent stewardship committee at Georgetown. We all just met today. We all carry the same common ground of wanting to do as little harm as possible. And I'm not a leading expert in antibiotic stewardship. As my co-fellow Joe Jiang would always tell me, I'm just an enthusiast. But the number one risk factor for C. diff occurrence is antibiotic use, and there's really no way around that. So just simply, we need to use less, and we need to be more mindful about how we choose. Clindamycin is the poster child for C. diff, and that's because almost all toxigenic strains of C. diff are resistant to clindamycin, so it very easily selects out C. diff. But we don't use clindamycin that often in our hospitalized patients. And our Achilles heel now are these broad spectrum penicillins like Zosyn, our higher generation cephalosporins like ceftriaxone and cefepime, and our carbapenems. And so we have a task ahead of us. We have to reduce our C. diff rates by at least a third. And we need to find a way to get even better than that and stay better than that. And we won't reach that through brute force restriction or shaming each other on antibiotic choices or ordering habits. We're going to beat these problems, teamwork, mindful choices, and commitment to resilience. And so I ask everybody to help us with this goal and help make our hospital safer.